Okay, welcome to part 2 of Introduction to Biostatistics for Clinical and Translational Researchers. My name is Jo Wick, and I'm a faculty member here at the University of Kansas Medical Center in the Department of Biostatistics and Data Science. Feel free to reach out to me by email. My email address is here and also at the end of the slides if you have any questions about the course or any other opportunities to learn more about biostatistics as it pertains to your research. Again, the lectures are being recorded, and I will send out links to registered participants this afternoon. For those of you who were able to join us last week, we covered, in a very short period of time, some topics related to scientific rigor and reproducibility of research. We defined rigorous science and the pillars of rigorous science, and we focused primarily on how probability and statistics plays a large role in how confident we can be in the accuracy of findings from research. The take-home points revolved really around sampling variability and how even in very, very well-conducted studies, there's always a risk of a false positive or a false negative finding, largely due to sampling variation. Sampling variation is caused by us working in samples as opposed to populations, because different samples across different studies, even when the studies are identical, will generate different results. What we try to do when we size our study appropriately is ensure that the results don't bounce around from study to study quite as much. They'll still vary, but not vary to the degree that it will impact our confidence in any findings. And so sampling variability is always a source of error. We talked about how the p-value attempts to quantify the impact of sampling variability, as does a confidence interval. And so we talked about the appropriate use of p-values and how if we contaminate them with other random variation, for instance, by switching our outcomes as a function of the random data, that the p-value is invalidated. We talked about the idea of repeatability and transparency, and that all studies should be able to be repeatable. It just requires us to have good documentation and protection of our data and openness, but not all studies necessarily can be replicated. Type 1 and type 2 errors, even though they are small, they are still real and can impact the findings of even a very well-done randomized controlled trial, and for that reason, we do tend to prefer to see findings replicated in more than one study because our confidence is increased in that case. We'll touch on how we can think about evidence across several randomized controlled trials today as we talk about experimental design. What I mean by experimental design is this process for trying to account for and minimize errors in our conclusions. And there are many opportunities for error, as you can see here. It could be within the process of designing the study. It could even be in the process of defining the research question, implementation, inappropriate analyses, inappropriate interpretation, inappropriate inferences. So lots of opportunities for error that we try to account for through this process called experimental design, which I'll talk about today. The goal for today is to think about how study design can impact or ensure the validity of our research. And there are two types of validity we tend to focus on. The first being our ability to draw valid conclusions about the effects of some intervention. And the second being trying to generalize those findings back to some population or setting of interest. We're going to focus on internal validity today, and that again has to do with how accurate the conclusion is from the study. One of the major threats to internal validity is bias. That's that systematic variation that can push our conclusion away from the truth in a particular direction. We're going to focus on how we try to account for sources of bias through study design today. And again, external validity, we won't spend much time talking about this, but it really has to do with how well the study can reflect the reference setting, the reference population. We talked about one major threat to internal validity last time, and that is the idea of an individual study producing an incorrect treatment effect estimate simply as a function of sampling variation. So the example that we had last time was we had a population of about 2,000 patients at risk. The true effect of this therapy is that there is a relative risk of 0.82, which indicates a 17% reduction in the risk of death for patients who get treated with this infusion therapy. And then I showed you 10 hypothetical experiments, randomized controlled trials, conducted in this population where each of these studies was conducted in the same way, but only in a random sample of 216 of these patients. And so the impact of sampling error here is very clear in the fact that these relative risk measures are all over the place. So again, an indicator of no treatment effect would be a relative risk of 1. And we see here that even when we have done things the right way with regard to using a randomized controlled trial, the gold standard of study designs, it's possible that we'll still get problems with our internal validity due to random error known as sampling variability or sampling error. The way that we tend to combat sampling error is by making sure our study is large enough to answer the question correctly with high probability. So we do that by stating that we want a false positive and a false negative rate of a certain small probability, and then we use the mathematics and the probability underlying the study design to determine what sample size is required in order to achieve false positive and false negative rates that are small enough. The idea here is we try to combat sampling error in many ways, but the primary way is through sample size calculation. The other source of error, the other threat to internal validity is bias, and that's not random error. In other words, those relative risks won't necessarily be jumping all over the place. Bias is that second type of error. It's a systematic error that pushes our conclusions in some direction away from the truth. So that will lead us to incorrect inferences, incorrect conclusions. Bias makes us think that the effect of an intervention is either much better than it actually is, or that it doesn't exist when in fact it does. So it increases our chances of a false positive finding, and it actually can increase our chances of a false negative finding in some circumstances. One of the major sources of bias in a randomized controlled trial is the idea that participants may drop out as a function of how well their treatment is working. So what I have here in this figure is a picture of, along this x-axis, just the patient ID. So patient number 1, and then all the way out to patient number 25. And then along the y-axis, we just have some indicator of whether the treatment effect was a positive effect for that particular patient. So dots above the line that are also shaded in green were outcomes for patients that were positive outcomes. And any dots below the line that are also shaded in red were negative outcomes. And if they're along the line, it's kind of negligible. So if we take a look at this randomized controlled trial where patients with a particular condition, they come in, they receive an intervention that is intended to make their condition better, to help it resolve, and then we follow them, let's say, for 6 months. And after 6 months, we have them come back, we measure their pain, their quality of life, or some other objective clinical measure of their disease, and see the eventual outcome. The problem with this, even in a randomized controlled trial, is that some of these patients may choose not to come back for that follow-up visit. So you may never see whether they had a positive or negative outcome. Very often, that choice is not random. It has something to do with their experience on the study. What can often happen is patients who are having either no benefit or some kind of negative effect, adverse effect of the intervention, those are the individuals who tend not to come back. So let's pretend I could see those individuals. So here are the ones that I was actually able to observe, and the average effect of treatment across these individuals is somewhere in the range of better, right? Sort of mid-range. This is the estimated effect of treatment over all of these patients. If I were able to observe those who did not return for that outcome assessment, 8 of those individuals didn't return, and 7 of those 8 ended up, if I had been able to observe their outcome, would have had negative effects. And so if I were to be able to see that missing data on these individuals who were lost to follow-up, it would drop my estimate of the treatment effect down toward the sort of the center line here where there is no effect. It's still a positive outcome overall for this group of patients, but notice the bias that exists due to this missing data. And so this difference between the estimated treatment effect whenever we have missing data versus complete data, that is the level of bias. And notice it results in an overestimation of the treatment benefit in these patients. It's just important that we report, for instance, how many individuals were lost to follow-up and how we handled that in the analysis. So we can understand, and our reader or the consumer of the research can understand the internal validity of the study. So back to experimental design, this process of designing a study. Many of the threats to internal validity can be mitigated through proper study design. We do that by trying to exert control over as many of those extraneous factors as possible. What do I mean by extraneous factors? I mean not the conditions of interest, not the treatments that are being applied. So can we do that over the way we include or exclude participants? So thinking about the criteria that would make someone eligible for the study. There can be some control exerted over there by making individuals with a certain mutation ineligible because we know that mutation is going to potentially bias the outcome. We also like to employ randomization to all of the conditions of our study. Randomization protects us against unknown factors that could increase the bias in our findings. We want to include control groups, withhold knowledge of assignment through blinding, when possible, use as objective of an outcome measure as possible, and again, size our study appropriately to minimize the impact of sampling variation. So this process of experimental design, this is what statistician, we spend a lot of time thinking about this. Now, we don't necessarily have the scientific expertise, which is why this is a collaborative process. It can't be done just by the statistician or just by the investigator. We often work together to account for all the potential sources of variation that could impact the internal validity of our study. In other words, that could impact our assessment of the relationship between the intervention and the outcome for patients. So through this process, we're just attempting to account for all those extraneous sources of variation, and in doing so, trying to minimize errors. So we begin with a research hypothesis, but we have to narrow it down to some specific testable research questions. From those research questions, that allows us to determine what is the intervention, what are the or interventions, what is the control or controls, what are we measuring, when are we measuring it, how are participants on this study going to be assigned to treatment, how are they going to receive treatment. You try to break your own study by thinking about, well, what could happen here to make this result inaccurate? And you think about the potential ways a patient could behave, the other things that they could be exposed to, the passage of time, for instance, in a migraine example, where if we don't observe participants in our study without treatment, we may attribute their natural progression of the migraine back to some normal state to an effective treatment. So thinking about all the ways we could potentially mess up the study, the result, and we try to minimize those sources of variation through study design. So when we think about study design, the primary differentiating feature is randomization. So we have a set of designs that are called observational, and they sit on the lower half of this hierarchy of scientific evidence. They're observational because they don't employ randomization. The thing that gets you to the top of this hierarchy of evidence is using randomization. I want to be clear, though, that even if you use randomization in a randomized controlled trial, you may end up with a study that is more flawed than a really good cohort study, which is an observational study, if you're not doing everything according to best practices. If study designs employ randomization, we know that they have that added protection of accounting for or mitigating unknown sources of bias by randomizing participants across the treatment groups. If it doesn't have randomization, then we're at risk of certain types of bias, which we'll talk about. Notice for this hierarchy of evidence that as we move from the bottom to the top, we are increasing our confidence in the evidence that's produced by the study, but the cost of that increase in confidence is added complexity. So they're at the top because they're more complex. And if they're more complex, they usually cost more, require more patients, more participants, and take a lot longer to conduct. For every decision that we make, there is always a cost, and that cost will come in terms of complexity and resources necessary. That's also one of the major reasons why we start with or end with observational studies, because of the lack of feasibility for some of these more rigorous experimental designs. So again, experimental designs really have to do, in essence, with conducting a scientific experiment. And the scientific experiment's purpose is to identify a cause and effect relationship. So the cause is the independent variable and the effect is the dependent variable. The only experimental design for an individual study is the randomized controlled trial. That's why we tend to call that the gold standard of evidence. We'll talk also today about study designs that incorporate actually multiple studies at once. For individual studies, they all fall below this line. Below this line are the studies that are observational in nature. In other words, these are the ones that only observe. Some of the defining features that place one particular design into one of those buckets versus another. I wanted to touch on these at the very beginning because you might see a study design that doesn't cleanly fall into one of those buckets. It might actually span multiple. Knowing the language can help you understand how that particular characteristic either lends to a strength or a weakness. So studies are either longitudinal or cross-sectional. The differentiating feature between a longitudinal study and a cross-sectional study is whether there is some kind of time component. Is everything happening at once, or are we trying to state that the cause came before and confirming that the cause came before the outcome? Forward versus backward directional, this is actually defined by what are the comparison groups. Prospective versus retrospective studies, this is just the timing of measurement. So if it's prospective, measurement is happening in real time. If it's retrospective, then we're actually collecting things that were measured in the past. Randomized versus non-randomized, we've talked about this as well. That's the defining feature between observational and experimental study designs. There are lots of ways you can randomize. Simple randomization is just randomly assigning treatment to participants, but you could also block your randomization on important confounding factors. You could stratify. You could do randomization that's not equal. It could be some kind of 2-to-1, 3-to-1 randomization, depending on what's optimal for the situation. And then there's something that's even more innovative called adaptive randomization, which unfortunately is beyond the scope of a 3-lecture series, but I would encourage you to seek out information on how randomization can be adapted based on accumulating data in a study. Controlled versus uncontrolled. Clearly, a comparative design would have a control group for comparison. The types of controls we use, though, you could have a concurrent control, which is one that is participating in the study, simultaneous to those who are receiving an intervention, or you could have a historical control where the information, the data for that is from a previous study that's already been conducted or published. Blinded versus unblinded, often called open label, and the blinding could be single, double, or triple, where you have just the patient and the investigator, the patient, investigator, and the analyst. And then, of course, repeated measures versus independent measures. You often hear this associated with the study design. Repeated measures means you're repeatedly measuring the same participant, or independent measures could be that you're measuring individuals just once, and so all the measures in your study are from independent individuals. You often hear this discussed in terms of within subject or between subject variation. Within subject variation is the repeated measures. You see that sometimes when you have crossover designs where an individual subject serves as its own control. And so all of those characteristics, you can kind of determine for each study what of those characteristics apply, and that would help you identify whether it's a cohort, a case control, cross-sectional, randomized controlled trial, or some combination of those classifications. The gold standard, of course, is the randomized controlled trial. So my plan here today is to begin with the randomized controlled trial, talk about all of the complexity associated with it and why that complexity helps us ensure internal validity, and then peel away one of those characteristics and show how that could lead to a weakness for a study. And then we'll work our way all the way down to cross-sectional and ecological studies, and I will touch on meta-analysis as well. Randomized controlled trials, those are the only true experimental studies in human subjects. And they're experimental because we apply randomization in the exposure assignment of each study subject. We also have prospective exposure and outcome measurements. It's a forward directional study. And we have what's called a concurrent control group. The concurrent control group is the type of control group that is participating on the study at the same time as the intervention group. These concurrent controls are a strength because they allow us to, again, exert control over as many of the other extraneous conditions that might cause these individuals to have outcomes that differ from what we would expect. This concurrent control group will allow us to measure whatever changes in these outcomes we would observe in patients under other conditions, and that allows us to get a better idea of the true treatment effect. And again, these studies are designed to test for causal relationships between exposures and outcomes. So these descriptors, I touched on them briefly before, but I want to spend a little bit more time talking about them, because if you don't understand what I mean by prospective or retrospective, by forward or backward directional, you might not understand why it's a strength or a weakness of a particular design. The prospective or retrospective descriptor indicates when the cohort of patients is identified relative to when their outcomes are measured. So in a randomized controlled trial, it's prospective because I enroll patients and then I measure, as opposed to having information already measured on a past set of patients and using it in my retrospective study. That sometimes gets confused with the forward versus backward directional descriptor. This one really has to do with what groups are we comparing. Are we comparing groups based on their exposure, their treatment, or are we comparing groups based on their outcome? So let's take a look at this visually. I think pictures are worth many words. Let's look at the prospective versus retrospective design. Whether a study is prospective or retrospective is determined by when a patient or a participant is enrolled onto the study and when their outcome is measured. In a randomized controlled trial, notice enrollment is at this location along the time axis identified by a circle, and then their outcome is measured wherever you see the triangle. So in a randomized controlled trial, sometime after a participant is enrolled, you measure their outcome. So that's prospective. A prospective cohort study we'll see later is just like a randomized controlled trial. It is prospective. We enroll participants. We measure their outcome at some point after that point in time. A retrospective cohort study differs from these two in that we are enrolling participants and then we're relying on either their electronic medical record or their own recollection of things that have occurred in the past. So the outcomes have either already been collected or we're asking about things that we were not able to observe directly. You can see the weakness here is we're more confident in the accuracy of our measurement of things when we're able to do it ourselves, when we're able to validate it and see it happening, as opposed to things that come from either patient recall or some kind of historical record. So sources of bias result as a function of using retrospective data. A case control study, we're relying on historical record or patient recall. A cross-sectional study is kind of weird because there really isn't a time component. We just know that these things have already occurred. So those are retrospective studies. These are prospective studies in terms of this particular characteristic and how the studies can be classified on that characteristic. Directionality, forward versus backward directionality. Think about the study in terms of what groups are being compared, the feature that drove sampling. So am I sampling based on their exposure? In other words, am I trying to accumulate 100 exposed individuals? So in that case, I'm sampling based on their exposure or their treatment. Or am I sampling based on their outcome? So 100 healthy controls versus 100 individuals with a particular disease. So sampling or randomization, how is that happening? And that determines the directionality of investigation. So randomized controlled trials, we randomize based on the exposure. They either receive the intervention or they receive the standard of care. This is a forward directional investigation. Forward meaning we begin with the exposure and follow forward. In a cohort study, it's the same. For a prospective cohort study, we sample based on their exposure. So we try to randomly sample a certain number of individuals who have been exposed to something, certain type of treatment, certain type of environmental exposure, and then we also try to accumulate those that were unexposed or some other adequate control group. So we're sampling based on their exposure and comparing those groups based on the outcomes. So for this reason, those two are identical in nature. They're both forward directionality. Retrospective cohort, same. We're sampling based on whether or not individuals were exposed and looking for differences in their outcomes. Here's where we flip-flop. Case control is sampling based on outcome. You sample cases, which are the individuals with a condition, and you sample a similar group of controls, which are individuals without the condition, so with and without the disease. And then you try to determine how they differ based on potential risk factors or exposures. So notice, randomized controlled trials, prospective cohort studies, both are prospective, both are forward directional. The differentiating feature between these two is randomization. Differentiating feature between prospective cohort, randomized controlled trials, and retrospective cohort is the prospective versus retrospective collection of information. And then the differentiating feature between the cohort study and the case control has to do with how sampling occurred and what are we comparing these groups based on. Cross-sectional study it's a non-directional study. You have typically measures of several different exposures and several different outcomes, and you're looking for associations. Forward directional, prospective, measurement, randomization, and those are the defining features of a randomized controlled trial. Each of those tools that we use increases the confidence that we have in the findings from a randomized controlled trial. Randomization ensures that the groups of participants that we're comparing the treated versus the control, are similar in all other respects at baseline. And then apply treatment so that at the end of the study, if we see differences in outcomes between those who received the treatment and those who received the control, we can be confident that those are due to this particular source of variation and not some other source of variation that was unbalanced between the two groups at baseline. So randomization is a protector against known and unknown sources of bias in the assessment of a treatment effect. Let's look at a randomized controlled trial where we have a treatment group and a control group. Participants, we had 200 total participants that we randomly assigned equally across these two groups. So we have 100 in each of these arms. And then we measure their outcome. They either have a positive outcome or they don't. When we calculate the estimate of the treatment effect, we often want to understand the chances of experiencing a positive outcome as a function of what treatment was received. So this is, for those of you who are familiar with this is just a proportion, right? The proportion of patients who received a certain treatment who experienced a positive outcome. And this, as a proportion, is also a probability. It's our best guess at the impact of treatment on these individuals who receive it. Notice that the denominator of this probability or proportion, those who receive treatment, that is determined by the design. It's fixed. It's not random. This becomes a key point later when we try to calculate measures of risk. So the denominator here, those who receive treatment, is fixed from the design. And the thing that is a function of the random data is the thing on the top. That's observed from the random data. So once we observe the outcome of these 200 participants, we can classify them into one of these four buckets. They either received treatment and experienced a positive outcome, or they received control and experienced a positive outcome, or they did not experience the positive outcome in either treatment or control. So 30 and 70 make up the 100, 20 and 80 make up the 100 in control. So if we want to talk about the chances of experiencing a positive outcome under a particular treatment, then we can take the 30 out of 100, or 30%, the 20 out of 100, or 20%. But again, the key here is what is fixed. And in this case, it is those receiving treatment, the factor that we were sampling on or randomizing on. The weakness of a randomized controlled trial is that it's not always feasible, not always ethical to randomize, so they can't always be conducted. Even though it's the gold standard, it might not be an option. They are also resource intensive. We have issues with compliance and issues with loss to follow-up. So for that reason, you often see in the literature associated with this type of study, you see this figure 1, which is a patient flow chart that helps us better understand, number one, is there a risk of internal validity based on patients not complying with treatment? In other words, did everyone who was randomized to receive convalescent plasma in this study actually receive the intervention as randomized? Or was there a lack of compliance? If you see a lack of compliance, you know that there's a risk of bias in the study findings. You also want to see the degree of missing data in the study. In other words, we randomized 103 patients, 52 to receive plasma, 51 to the standard treatment. Did we observe the outcomes of everyone who was randomized? If we didn't, we might have a situation where, for instance, the example I gave before, where individuals who are having negative outcomes or are not experiencing what they feel like is a benefit of the study are dropping out. So loss to follow-up, if you see that a large number discontinue, then you have a risk of bias associated with the missing data that comes from loss to follow-up. Individual randomized controlled trials, even with adequately sized trials, we have the false positive and false negative rates. Even though they're small, they're not zero, leads us to the concern about changing practice with a single randomized controlled trial. So a single randomized controlled trial is still at risk. Another limitation is that the individual study might have been conducted in a very specific setting or a very specific population, and so it may not generalize across a heterogeneous population or to many settings. So we have to think about that when we assess the evidence from an individual randomized controlled trial. We can be highly confident but still cautious. And that leads us to the top of the pyramid of scientific evidence, which is the systematic review and the meta-analysis. The randomized controlled trial is the gold standard for an individual study. The fathers of experimental design, though, really didn't intend a single randomized controlled trial to be the epitome of evidence. They indicated that they would like to see three replications across 3 independent studies before practice would be changed, before you could determine cause and effect, if you will. So the tools that we have to try to synthesize evidence across several randomized controlled trials are called systematic reviews and meta-analysis. The systematic review is it's a narrative synthesis of all of the high-quality research that was conducted to answer a particular research question. Meta-analysis is the statistical analysis. It's a statistical model that attempts to pool together the results, the findings from 2 or more primary studies that addressed the same hypothesis in, for the most part, the same way. So this is a statistical analysis. This is the narrative. You can see just the narrative by itself. You might see the narrative with a meta-analysis. The benefit of a meta-analysis is that it can provide a better picture of the overall state of evidence for a particular question. When you're conducting a meta-analysis, you systematically explore studies that were designed and conducted to answer a particular research question. Then for each of those studies, you look at the strengths and weaknesses of each of them. You can also look to see how the results from all of these studies vary. And that gives you an idea of the impact of sampling variation on study findings, because this is kind of like the example where I showed you 10 different studies to answer the question about whether the infusion therapy worked, where we saw the relative risk kind of bouncing around all over the place. The meta-analysis would tell us there's a lot of sampling variation here, that these studies are at risk of sampling error, and then the strength of the accumulating evidence is not very strong. Other sources of heterogeneity in findings could be the designs themselves. So you might have many randomized controlled trials. Some are higher quality than others. Some maybe didn't blind. Some of them were longitudinal. Some of them used a slightly different intervention. Some of them used a slightly different measure of the treatment effect. So you can look at the potential source of bias in each of the studies and then pool together the findings from all of these studies, taking into account their individual risk of bias through some kind of weighting toward the overall estimate, and get an overall estimate of the benefit or harm of a treatment. So it's a great tool that we can use to determine the current state of evidence. So for those of you who are doing clinical research, if you're planning on doing a randomized controlled trial, or if you're reading a lot of the clinical trials literature, you should be aware of something called the Consort Guidelines. The Consort Guidelines really provide a set of criteria for reporting the results of different types of studies, randomized controlled trials, observational studies, and so forth. And they give you a good idea of the quality. They allow the reader to better assess the risk of bias. For a systematic review and a meta-analysis, there is a similar set of guidelines that exist that give you basically the instructions for reporting the results of a systematic review or a meta-analysis. And the process looks like almost exactly like conducting a research study in patients. You define the research question, you enroll the studies, you can think of these as the participants, and then you measure and combine the results and interpret. You're just doing this now on individual studies as opposed to individual study participants. In these guidelines, which are called the PRISMA guidelines, you also see, remember the figure 1, the patient flow chart, to give you an idea of bias. You have the same thing here, but now instead of a flow chart for study participants, it's for the studies that were included in the meta-analysis. These guidelines, you can find the PRISMA guidelines here in PLOS. Another protection for scientific rigor and reproducibility that exists not only with meta-analysis and systematic reviews, but also with individual studies is to pre-register your protocol. Develop your protocol, get it approved, and then register it. Say what we're going to do, we register it so everyone knows what we're going to do before we do it, and then we are held accountable by our peers. It allows us also as readers, consumers of the literature, to go and see for a study, did they pre-register their protocol? And if they did, are they reporting the findings according to the way that they said they were going to do it? So it gives us a measure of the risk of bias for studies as the reader. So pre-registering, search the literature using the PICO method, where you search the patient population indicators, the type of intervention, the type of comparator, and the type of outcomes. Putting these four search terms into something like Google Scholar or PubMed will pull up all of the different types of studies conducted toward a research question. And then you can assess the studies once you've determined which ones are included, do a critical appraisal of risk, of bias, and generalizability, and see if there are any statistical issues. Why do we do this? Well, that's because this meta-analysis is a statistical analysis. So if you put garbage into it, you will get garbage out. So we want to make sure that we understand the risk of bias for the things that are going into our analysis. Then you want to combine the results using the meta-analysis and put the findings in context. So let's focus a little bit on how do we combine the results? Underlying this is just a regression model. It's a regression model that tries to take the individual treatment effects from each of the studies and average them. And the average is a weighted average, where a study, its estimate of the treatment effect will provide more weight if it has less risk of bias. And a study will provide less weight toward the overall estimate if it's at a higher risk of bias. So it downweights the individual study evidence as a function of its quality. So if it's low quality, the weight goes down. High quality, the weight goes up. Meta-analysis just means the analysis of analyses, and it answers several questions. It answers the direction of the treatment effect. Is it positive or negative associations? The size or magnitude of the effect, the consistency of the effect across studies, which we call heterogeneity, and the strength of evidence. So if that's related to the heterogeneity, the higher the consistency, the higher the strength of evidence. The lower the consistency of this effect across studies, the lower the strength of evidence. Visually, meta-analysis gives us a lot of cool tools for looking at the current state of evidence, the first being the forest plot. So if you take a look at a meta-analysis from the literature, what you often see is something like this. It's a table, you see lots of different studies, some descriptors, and then you see these lines for each of the studies. And this is called a forest plot. And what it's trying to convey to the reader is not only the overall estimate of the treatment effect, but the heterogeneity among the effect estimates across all the studies, the direction of the effects, and the size of the effect. For this particular study, which I have given you the citation here, the treatment effect estimate is the risk ratio, which we talked about last time. You take the risk of the outcome in the intervention group and divide it by the risk of the outcome in the control. This one is comparing corticosteroids and a control group. And so this outcome, what we see is if we have an estimate of the relative risk equal to 1, the x-axis here indicates whether an effect favors the control or favors corticosteroids, or is the null. It's the null, right, where there's really no difference. So if you see a relative risk equal to 1, that indicates that there's no difference between corticosteroids and control. for the risk of this outcome. If you see something to the left, as indicated by either this line, this vertical line, or this blue box, and I'll talk about what the differences are there, that's the point estimate. That's the actual relative risk. So here the relative risk is approaching 0.1, which is a pretty large effect. Here it's a little bit closer to 1. It's maybe 0.5. This one's getting even closer to 1. It's about 0.85 or 0.9. This one is even above 1. So this indicates actually evidence that favors the control just slightly. Maybe it's a 1.1 or 1.01, something like that. So the marker here is the estimate of the effect, and then you also see the lines that extend beyond that. That's the confidence interval, and that provides us, again, the measure of the precision of the estimate, a measure of the impact of sampling error on the estimate. So if we see a really wide confidence interval, for instance, this one, we mentioned that this effect, the relative risk, is, maybe 0.2, but look at how wide the confidence interval is. This confidence interval is telling us it could be as low as 0.01 or as high as 1.2 or 2.0. And that's basically evidence of low quality, because we have different conclusions that could be drawn based on the values of the relative risk that are included in this interval. We could conclude in favor of control, we could conclude that there is no effect, or we could conclude a very strong effect of corticosteroids. So this is low quality evidence. And when we see wide intervals like that can kind of span different conclusion regions, we know that the evidence is of low quality. In addition to the relative risk estimates and the confidence intervals for individual studies, you get the overall average, and that's this diamond here. The diamond here tells us if I were to pool all this together, weight it based on its quality, this is my overall estimate of the effect of corticosteroids, and that is slightly less than 1. The size of each of these markers represents the quality or the weighting factor. So it has to do usually with the impact of sampling error on the result, the impact of bias. So if you see a bigger box, you're going to have that particular study provide more weight toward this finding. Notice these two align almost perfectly, and that's because this estimate of the relative risk contributed almost 20% of the evidence overall, whereas something that's a smaller, you can't even see the blue here, only contributed about 2%, 2.5%. Also notice that the studies where the intervals are very precise, more narrow, contribute more evidence than those with a lot of uncertainty. And the combined result is this diamond, where the center is the overall estimate and the width of the diamond spans the confidence interval. In addition to looking at the overall level of evidence, we want to think about the heterogeneity, because heterogeneity of treatment effects is a kind of a measure of the strength of the accumulating evidence. If we see a lot of heterogeneity across these studies, in other words, that relative risk is bouncing around above and below 1, then we would say that the current state of evidence is weak. But if they're all in the same direction and pretty consistent, then we might be able to conclude that there's a strong current state of evidence. And so when we think about heterogeneity, there's lots of reasons why a relative risk would bounce around, right? We've already talked about sampling variation being a problem. It could be that the study populations across these different studies were slightly different. Their ages could have been slightly different, their sex, their comorbidities, whatever. Could be that the interventions have slight differences, the outcomes were measured slightly differently. It could be methodology, again, sample size, protections against bias, and so forth. So lots of reasons why you might see two different studies of the same thing provide two different answers. And so the idea here is we need to have both a visual inspection of the heterogeneity. We can do that by looking at the forest plot and seeing, well, most of these actually are favoring corticosteroids. At least they're to the left. Some of them have lots of uncertainty associated with them, so they cross the 1 boundary. But the general view is that these estimates are to the left. There are other statistical representations of heterogeneity, something called the I-square statistic I like because it is a really easy to interpret measure of heterogeneity. If you think about the I-square statistic, it's just a proportion, a percentage. And here you can see the I-square is a 32%. And so what this statistic is telling me is that the variation that's observed in these treatment effects, about 32% of it is likely attributed to true heterogeneity, population differences, differences in interventions, differences in outcomes, differences in methodology, as opposed to just the usual sampling variability. So 32%. And there are a couple of rules of thumb for this I-square statistic. Of course, you want this to be low. You want the studies to be similar and provide similar findings. But if you see 0 to 40% I-square, most people agree that that's probably nothing to be concerned about. Once you get, around 60 and above, that may indicate moderate to substantial heterogeneity of effects. Heterogeneity that's attributed to differences in studies, which basically means that the accumulating evidence is just not strong. There's too much heterogeneity in studies that's causing the effect of the treatment to bounce around. So I've made meta-analysis sound fantastic, but it also has its limitations. Again, garbage in, garbage out. And one of the reasons why a meta-analysis might not be internally valid is the concept of publication bias. Most people have probably heard of publication bias, and it's the idea that studies that find something are more likely to be published. You have a statistically significant result, you're more likely to spend the effort trying to get it published. Journals are more likely to publish it. And so if you're getting more statistically significant findings, more favorable evidence into the literature, then if you take what's there, what you can actually see, and put it into a statistical model that pulls it all together, you're going to get a biased, more favorable than it should be, overall estimate of the benefit of treatment. Publication bias is a big problem, and here's another cool reference that shows statistical evidence for publication bias. It's a really cool. How do we know whether or not a meta-analysis is at risk of publication bias? That's the funnel plot. This funnel plot is often not provided in the publication itself, but in a high-quality journal, you'll be able to find it maybe in supplementary material. So for instance, in New England Journal of Medicine or JAMA, if you see a meta-analysis, you might go look at the supplementary tables and figures for the funnel plot. What you want to see in a funnel plot is a funnel. A funnel indicates that there's no major concerns with regard to publication bias. If the funnel plot looks unlike a funnel, then you have publication bias. So how do I read this? The funnel plot, what it has here is along the x-axis here is a measure of the treatment effect. For instance, the relative risk, just like what we had before, right? So a value of 1 would be a negative finding. There'd be basically, there's no association between the treatment and the outcome, or it's no different from the control. Any value to the left favors the intervention. Any value to the right is basically unfavorable for the intervention. It favors the control. So along the x-axis, you'll have a measure of the treatment effect. Along the y-axis, you have a measure of the impact of sampling error, basically. So as we notice that this axis is actually inverted, 0 is at the top. So studies at the top here are studies that are really high quality, large, randomized controlled trials. And so this top of the funnel is like the highest quality single study that was included in the meta-analysis. It provided evidence of a 40% reduction in risk, so the risk ratio is about 0.6, and it had very minimal impact of sampling error. As we move down the figure, we're increasing the impact of sampling error, probably because the study is smaller. So these two, again, they provide similar evidence, right, about a 50% or a 30% reduction in risk, slightly more sampling error, so we expect them to kind of bounce around a little bit more. And the further we move down, notice the more they're bouncing around. And that's what we would expect. As the impact of sampling error grows from 0 up to 3, as its impact grows, we expect to see the relative risk estimates bouncing around, just like our initial example from day 1. So in the absence of publication bias, you see both the positive studies and the negative studies across all levels of sampling error. And you, by the way, would expect to see more sampling error associated with both positive and negative findings. The publication bias occurs because these studies right here that were at high risk of sampling error and also produced either null or negative findings, those just didn't get published. Either the investigator chose not to publish them or didn't take the time, or maybe it's going to take a lot longer to get it published, or the journals wouldn't accept it. And so when those end up not being in the literature, they don't get into the meta-analysis, and then you end up with a funnel plot that looks like this, where you have this big gap here. And this would result in an overly optimistic estimate of the relative risk. Notice that this is the estimate when all of the studies are combined. It's 0.6. And the estimate when these negative studies are dropped out is shifted over to the left. It looks better. It's like 0.5, so it looks like a 50% reduction as opposed to only a 40% reduction. So that's the benefit of the funnel plot. If you ever come across a meta-analysis, it's important to take a look at that because it can get you an idea of the risk of publication bias in the meta-analysis finding. Now, clearly, if a meta-analysis only uses 2 or 3 studies, the funnel plot won't be of much help. And so there are, just like in small studies, there's risk with meta-analysis that's conducted in just 2 or 3 studies as well. Search bias is also another limitation of meta-analysis, so you have to make sure, this goes back to this figure. This can tell you a little bit about whether there were search bias. So you have to understand how were the studies that were included, how were they identified? And also, how were the ones that were excluded, why were they excluded? And so understanding that from the protocol that's pre-registered or from the publication itself is important for understanding whether or not there is a selection bias at play. So we've covered randomized controlled trials, the only experimental design for a single study. We've talked about their limitations and how a meta-analysis can help us overcome that. Now let's move below that randomization line and look at observational designs for single studies. We've already talked about some of the differentiating features, but let's see them pictorially, I guess is the right word, to make sure that we understand. An observational cohort study, just one step down from a randomized controlled trial, does not employ randomization, but they have a forward direction of inquiry, and they're designed to test the association between treatment and outcome or exposure and outcome. There are 2 types of cohort studies. Prospective cohort studies are the ones that look like the randomized controlled trial. They employ real-time enrollment and measurement of outcomes. Retrospective relies on either patient recollection, electronic health records, or historical measurements. So there's a risk of bias associated with that. So visually, the prospective cohort study, notice it looks a lot like the randomized controlled trial. We have our population of interest. We sample from them and just observe or measure their treatment or exposure. Maybe some of these individuals received a surgical intervention and some of them received some other pharmaceutical intervention, but we don't try to exert control over that. We just observe what occurred. And what occurred happened as a function of physicians' knowledge, right? A physician's best understanding of what the patient might benefit from. So there's a systematic assignment of individuals to these 2 groups, and we follow them forward in time because this is prospective measurement to observe their outcome. And again, the direction of inquiry is forward, which means we are comparing these groups that are defined by the exposure based on these outcomes. The difference between the prospective cohort study and the randomized controlled trial is the issue of selection bias. So that's what brings it down the hierarchy. We no longer have assurance, because of randomization, that the groups of patients are similar in all respects, with the exception of this exposure. There could be some other characteristic that would be associated with why they received this treatment instead of this control. Notice the time. The time is prospective. Retrospective controlled trial looks exactly the same, except notice here we are in time. I should have been clear. This is where we are in time when the study starts. This is where we are in time when the study starts. Everything has happened in the past, and we are collecting that information based on recall or health records. So not only do we have the issue of selection bias because of a lack of randomization, but because we have retrospective measurement, we have information bias. Information bias is when the measurements, the data is at risk of errors because we were not allowed to ensure its quality. Let's take a look at the impact of the non-experimental approach in patients with MI. So suppose we have a population of individuals, of patients with this heart condition. We're using a non-experimental approach. So we're just observing what kind of treatment they received, and then we're going to observe their outcome, which is the outcome in this study is going to be mortality. In the treated group, of which there were 1,000 participants, there was an 18% mortality rate. In the control group, there was a 30% mortality rate. The issue here in the non-experimental approach is this idea of selection bias. Selection bias, it could be systematic and well-known, or it could be something lurking underneath the study that causes the bias. And the thing that's lurking here is this, what we call a nuisance factor or a lurking factor, and it's the presence of a particular arrhythmia. And this arrhythmia, if you notice, let's look at the distribution of this arrhythmia, the prevalence of the arrhythmia in the treated group. We end up with 800 of the individuals who do not have this arrhythmia. That's the negative sign, and 200 who do. So about 20% of the treated group have this arrhythmia. And about 500 or 50%, 500 out of the 1,000 in the control group have the arrhythmia. So more of the control participants have this arrhythmia than the treated group, 50% versus only 20%. Why do I care? I care because this is a confounder. It's a confounding variable because the presence of the arrhythmia automatically increases mortality. Notice among the 200 who received treatment and also had the arrhythmia, 50% of them died. 100 out of those 200. 250 out of the 500 in the control, 50% of those with the arrhythmia died. If I look at those without the arrhythmia, it's only 10%, regardless of the group. And so this imbalance in the arrhythmia, where more of these control participants also happen to have this arrhythmia, that is the reason why we see a difference in outcome. Notice we would associate increased mortality with the control relative to the treatment, when in fact there's really no difference. It's just a difference in the presence of the arrhythmia. The experimental approach, in other words, employing randomization, protects us against this unknown nuisance factor arrhythmia. What does it do? It takes all of the patients that are eligible and randomly assigns them to the treatment or control. I wasn't consistent about what I called this, treatment or control. What that does is, in large enough studies, randomization ensures an equal distribution of these unknown factors across the two groups I'm comparing. Notice randomization, when I have 1,000 and 1,000, has put 35% into, the breakdown is 35 versus 65% with and without the arrhythmia in the intervention, and the same distribution of that arrhythmia in the control. And so what that does is it spreads that increased mortality risk equally across the two groups. So at the end, I'm able to see that there really is no difference in mortality rates associated with the intervention. What differences I saw here was due to this confounding factor, arrhythmia. So that's the benefit of randomization, and the major weakness of any observational study is the lack of randomization, because if we do not know that that arrhythmia either exists or increases mortality ahead of time, then we don't account for it in our study design. Randomization will protect us against that even when we don't know about it. So that's one of the major weaknesses of an observational study. Observational cohort studies have, again, selection bias issues, loss to follow-up issues if they're prospective, and information bias or misclassification bias if they're retrospective. Those two types of bias have to do with the errors in our measurement of the treatment that they receive and of their outcome. But they have a lot of strengths. They're very efficient. They're very efficient for rare exposures. What do I mean by that? If only 100 people in the entire world were exposed to something, I can reach out to them and try to get as many of those 100 people on my study as possible, right? And put them right here. And then I can go out and try to find meaningful controls. So if you have a rare exposure, a cohort study is probably the optimal design to select. If they're retrospective studies are always more efficient because the data already exists. You just have to get it. They're good for situations where there's a very long time between an exposure and the outcome. If you were to do a prospective study where you have to wait 25 years to observe the outcome, that's very inefficient. So we like to rely on historical data in that case. And of course, they can estimate the risk of disease. What do I mean by that? Remember when I talked about the importance of understanding what is fixed from a study design? It has to do with what are you sampling based on. In this case, we're sampling based on the treatment, right? Either they were exposed or unexposed. Then the random data tells us how many died and how many were alive after a period of time. And this is the definition of risk given a particular treatment, counting the number of deaths out of the number who were exposed to the treatment. And so this risk ratio, the risk of that particular outcome or event, is just the probability of the event occurring given the total number who were at risk of the event in the group, where the denominator is fixed from the study design. This is different from the odds ratio, though. Risk is probability of event, odds, for lack of a better term, is likelihood of event. And this is a hang-up point. First of all, why would we report risk or odds? When do we report one versus the other? And the meaning, the interpretation. It all has to do with the study design and what number is fixed. The risk is the number with the event divided by the total number at risk of the event. So it's just a proportion or probability of the event occurring in a group of individuals. The odds is different. The odds, you take in the numerator the number who experienced the event and divide by not the total number at risk of experiencing the event, but the number out of the total who didn't experience the event. In order to estimate risk, the denominator, the total number at risk, must be known from the design. That's why the cohort study allows us to estimate risk. If we don't have the total number at risk fixed, if that is random, then we report the odds. Let me give you an example. In this case, the risk of death in the treatment group was 30%. The risk of death in the control group was 20%. The risk ratio is 1.5. I take the risk in the treated group and the risk in the control, and that gives me a 1.5. And the interpretation is how far away from 1 is this? Well, it's 0.5 or 50%. So the treatment is associated with a 50% relative increase in the risk of death. If I were taking a look at the odds of death in the treatment, I take the number who experienced the event and divide it by the number without the event in the treatment group, and that's an odds of 0.43. Odds of death in the control is 20 to 80 or 0.25. I can interpret the odds of death in the treatment group the 3 to 7 odds means that in every 10 patients who receive treatment, I would expect 3 to die and 7 to survive. And then the odds ratio, where I take the odds in the treatment group and compare it to the odds in the control, is 1.71. That just means that treatment's associated with a 71% relative increase in the odds of death. So it's higher odds in the treated group than in the control group. Observational cohort studies, we've talked about their strength. Their primary strength here is they're efficient, and they can estimate the risk of disease. They can estimate the risk because the denominator, the total number at risk, is fixed from the design. It is not random. Again, the major weaknesses in terms of lack of randomization, you can try to overcome that. There are imperfect attempts to mimic randomization through things like propensity score matching. Propensity score matching is just an attempt to use a statistical method to mimic randomization. It is imperfect, but it is one way to strengthen the evidence from an observational cohort study. Case control study, also observational. The biggest difference is that it's a backward direction of inquiry, and study subjects are selected based on their outcome, not on their exposure. And they are retrospective. So let's take a look at this picture. It kind of looks like, at first glance, a retrospective cohort study, but it's not. In the retrospective cohort study, we measured their treatment or their exposure, and then we had 2 groups, those who received an intervention and then a control, and then we looked to see how they differed based on their outcome. Notice we've reversed. Here we're interested in an individual's disease status. We have a set of cases, and then we select a set of healthy controls, individuals that are very similar to these individuals in as many respects as possible, except they lack the disease or the condition of interest. And then we look to see, well, how do they differ in terms of risk factors, behaviors, exposures? And so we're comparing diseased individuals with healthy individuals, trying to identify what potential exposures or behaviors could explain why certain individuals develop the disease and others do not. So again, we don't have randomization, so we have selection bias. We're relying on retrospective measurement. Clearly, when we are designing the study and conducting it, the individuals already have developed the disease. So everything's occurred in the past. We have to look and rely on recall for exposure information. So retrospective measurement, again, leads to information bias and misclassification bias. Just like with the other studies, we're trying to establish kind of a timing between certain exposures and this disease. So the exposure occurred prior to the disease, and they're also efficient for rare diseases because if I know only 100 people in the world have this particular rare disease, I can reach out directly to that population and try to get as many of them as possible to participate. Whereas if this is a very rare disease, it's only going to ever occur very infrequently. I would have to screen a lot of people, or I would have to follow a lot of people for a very long period of time just to get one case if I were doing this in a forward direction of inquiry where I'm sampling based on exposures. So very efficient for rare diseases. They're good for studying several exposures simultaneously. You're not limited to just one of these. You can look at all different types of exposures and see if any of them help explain why certain individuals get disease. And in these studies, you compute the odds of disease or exposure. Why do we compute the odds? Notice in this case control study of HPV, they have patients with the disease, patients without it, and they're reporting odds ratios here. Why are they doing that? And that has to do with the fact that the denominator of risk is not fixed from the study design. If you look at the abstract of this study, they selected 100 patients based on their disease status. They had to have oropharyngeal cancer, and then they found 200 control patients. So what's fixed here is this. It's fixed by the design, 100 and 200, but it's based on their outcome, right? Disease versus healthy. If we were to calculate risk of disease, we would need these things to be fixed, but they're not. What's fixed is this. All of this other stuff is random. And so that is why when we calculate, we would not want to calculate risk here because the denominator of the calculation is not known or fixed by the design. But we can calculate the odds. The odds of having cancer, assuming you have a family history. So that's this column. Patients with cancer is 26, patients without cancer is 27, so 26 out of 27, or 0.96. The odds of having cancer with no family history, 74, 173 is 0.43. Notice the interpretation here, this 26 to 27 odds in those with a family history of cancer, that it basically indicates that in 53 patients with a family history of cancer, we would expect 26 of them to develop it and 27 not to. So it's almost a coin flip, right, if you have a family history. And for individuals with no family history of cancer, we would expect 70 out of, 200 and 340 something, 47. Out of that many, we would expect 74 to develop it and 173 not to. So when we compare the odds, it gives us an idea of how much larger the odds are of cancer in these two groups. So putting the risk factor in the numerator, the control in the denominator, we end up with a 0.96 and the 0.43, which indicates that family history, this risk factor that we're investigating, is associated with a 123% relative increase in the odds of developing cancer. How do I know it's 123? Well, it's just how far away is this number from 1? It's 1.23 or 123%. So it gives you an idea of the association between certain potential risk factors and the odds of developing a cancer, but no risk, again, because we would need these quantities to be fixed in terms of the intervention or the exposure as opposed to the outcome. Case control studies, the weaknesses, the major weakness is it cannot estimate risk of disease. It doesn't employ randomization. It's retrospective. So because it's retrospective, it's dependent upon the amount and quality of historical record or subject recollection. Cross-sectional studies down here at the bottom. So we, again, randomized controlled trials, systematic reviews, meta-analyses, experimental, so at the top, cohort studies, slightly below because they don't employ randomization. Some are prospective, some are retrospective. Case control studies are retrospective. Cross-sectional studies are retrospective, and they are descriptive only. You're basically sampling, you're looking at collecting historical data based on both exposure and outcome. It might be that you're just grabbing data from a population, and there's not really a directionality of these. We're just looking for associations because we're not necessarily verifying that exposure, a certain exposure occurred prior to an outcome or vice versa. So notice there's no time axis here. We just define the population. We collect information on lots of different exposures and lots of different outcomes, lots of different diseases usually. And then we classify them into different groups to look for associations between certain exposures and certain outcomes. So because of randomization, lack of randomization, we have selection bias. Because of its retrospective nature, we also have issues with the quality of the data, the completeness of the data, whether or not the data that was collected is representative of this true larger population. But the cool thing about cross-sectional studies is they're quick and inexpensive. And we like to start here, right? We don't want to dive right in when we don't have a whole lot of evidence to support a randomized controlled trial. We need to begin somewhere. So these registries, for instance, that collect data on different patient populations allow us to perform these really important cross-sectional studies to generate hypotheses. They do have their weaknesses because they can't establish timing between exposures and outcomes necessarily. They cannot identify what are called incident cases, which means, you might see a diagnosis in the data set, but you don't know if that's their first diagnosis of the condition or if it's a subsequent one. If conditions occur quickly, you really can't, and they resolve quickly, you might miss them if they are acute conditions. But they are quick and inexpensive and can study or generate many hypotheses that could inform the design of case control or cohort studies. Ecological studies is where I'm going to end. Ecological studies are just studies in populations using aggregate data. So they're descriptive, a lot like a cross-sectional study, but instead of having measurements on individuals in a population, we have measurements at a group level. So for instance, at the county level, the zip code level, the state level, the country level, or maybe snapshots in time, like in 2020, 2019, 2018. So aggregate data. And then we use that aggregate data to examine associations between average exposure levels and average outcomes at those group levels. Here's an example of an ecological study looking at the association between the strength of firearm legislation and the rate of firearm-related fatalities across all the 50 states in the United States. And so what we have here is we don't have data on each individual. We have data at the state level, and we're asking the question whether or not more firearm laws in a state are associated with fewer firearm fatalities. And there's a couple of outcome measures. They look at the independent variable is the legislative strength score. It's basically a numeric measure that tries to summarize the amount and the restrictions a state legislator has put on firearms. And so the higher the value, the more restrictions. And then firearm-related fatalities, it's a state-level fatalities. It's a number scaled per every 100,000 individuals per year. So it's a measure sort of the risk of a firearm fatality in a state. And you can see here, they've given what's like a heat map where you can see the mortality rate per 100,000 in the population as a function of the color. We're used to this, right, from COVID? We see these kinds of plots all the time. Where are the hot spots? And this is a similar type of analysis. In this particular study, they want to look for an association between the amount of firearm legislation and the amount of individuals dying or the risk of death. In ecological studies, the reason why we conduct them is because, first of all, you might see these trends at a population level. And so these population level studies can help define and investigate important public health problems and help us generate hypotheses regarding causes of those problems where that information could be used to design a study that will look at individuals rather than population level aggregate data. Another reason why we might conduct an ecological study is because some of these individual level risk factors for disease, or even in this case for firearm death, they may not vary enough within populations to identify or study their effects. So in this case, they're looking at the association between the legislative strength score. The larger it is, the stronger the legislation, and the risk of firearm death from 0 to 20 per 100,000 individuals. So the higher higher on the y-axis means the higher rate of firearm deaths. And what you see is, as legislative strength, the more legislation they have in a state, you see a decreasing trend in firearm deaths in general. Looking at this same legislative strength score along the x-axis and the rate of household firearm ownership, it turns out that in states where there is higher more firearm legislation, they also correlate, not surprising, with fewer households with firearm ownership. So there could be some confounding here. When we look at household firearm ownership, it is positively associated with firearm deaths. So it could be an exposure, increased exposure results in increased risk. And so in ecological studies, they try to tease out some of these associations. One of the major weaknesses with an ecological study, not surprising, is something called the ecological fallacy, where since we're measuring both exposures and outcomes on a population, an aggregate, a viewpoint of it, that aggregate relationship may not translate when we are able to measure them at the individual level. For instance, this is an ecological analysis. We have some exposure along the x-axis, small to large, some outcome along the y-axis, small to large, and I've done this across 4 different countries. So this point is aggregate exposure and outcome for country 1, aggregate exposure and outcome for country 2, country 3, and country 4. If I were to look at this ecological study, it would look like as I increase exposure, I'm increasing this outcome. But suppose when I look within each of these countries, if I were able to see the individuals that make up this aggregate within country number 1, let's say I have 50,000 individuals and this is the plot of their exposure and outcome in that country. Within country 1, there's actually a decreasing relationship between exposure and outcome. In fact, there's a decreasing relationship between exposure and outcome in country 2, in country 3, and in country 4. So what I'm seeing in this figure is not a true negative association between, or excuse me, a true positive association between exposure and outcome. I'm seeing systematic increases in the average of both the exposure and outcome across these countries, where if I were able to drill down, I'd see the true negative association between those. So it's more a feature of country as opposed to a feature of the individuals. And that's the ecological fallacy. So in summary, not all evidence is of the same quality. As we're reading the literature, it's important for us to understand the defining characteristics of a research study and how each of those characteristics, when employed, can either increase or decrease the level of evidence produced by the study. The study design, all of those different characteristics are put in place in an attempt to account for as many known sources of variation as possible. Randomization is kind of like that final barrier, right? It's the final thing that we can employ to help us eliminate or minimize the impact of sources of variation that we don't know about in advance, which is why the randomized controlled trial is the gold standard of individual studies. In part 3, we're going to get into the statistical analysis, because an important part of experimental design is determining the appropriate statistical methods that we need to use to also help account for variation. And so, for instance, we can do a randomized controlled trial comparing 2 groups. We set our inclusion and exclusion criteria in a certain way. We size it appropriately. We determine that the 2-sample t-test is appropriate. We will talk about, we'll link this idea of accounting for variability in an outcome to the tool that we use to analyze the data. The t-test accounts for 2 sources of variation. A regression model could be used in place of the t-test that would allow us to do the same thing the t-test does, but account for additional sources of variation that we knew about and measured. So we're trying to account for them not in the inclusion-exclusion criteria, not in the randomization, but explicitly in the analysis. And so that's what we'll pick up on next time. We'll go through some of the most common tools for analyzing data, and we'll pull from the literature and take a look at examples, talk about strengths and weaknesses of approaches, and proper interpretation.